Good afternoon. Thank you for attending the RTI-sponsored webinar, How to Improve Addiction Treatment by Systematically Tracking Patient Outcomes. RTI is a nonprofit research institute dedicated to improving the human condition. This webinar is part of a series of webinars that we are sponsoring focused on reducing the impact of the opioid epidemic and improving the quality of addiction treatment. Before we start, let me provide a few logistics. You can submit a question on the bottom left of your screen at any point during the presentation. We'll be answering questions after each presentation. You can find a PDF of the presentation and additional resources under the headshot image located on the left of your screen. If you have any questions or problems during the presentation, please email Melissa Pangaro for assistance. NADAC credit is available for the program, but please make sure that you stay to the end of the presentation so that you can receive credit. We'll begin the webinar by summarizing the research on two applications of outcome measurement in addiction treatment: measurement-based care and provider feedback. Then our next three presenters will give you real-world examples of how they are using measurement-based care and provider feedback in their practices and in state government. My name is Tammy Mark. I am a Senior Director of Behavioral Health Financing and Quality Measurement at RTI. I will be moderating the session today and also giving the first presentation. So what is measurement-based care? Measurement-based care can be defined as the routine measurement of disease symptoms, signs, or biomarkers in the course of clinical practice. It's also sometimes referred to as routine outcome monitoring, treatment progress monitoring, and patient-reported outcomes monitoring. Measurement-based care is routinely used for physical health conditions. Two examples are blood pressure measurement and hypertension management, and blood glucose testing and diabetes management. This slide shows you an example of some questions from the Brief Addiction Monitoring Scale, or BAM, which has been used as a measurement-based tool in the VA. You can see that the key feature of the tool is that it allows a clinician and the patient to track their progress systematically over time. Why would you want to do measurement-based care? Or in other words, are clinicians already tracking outcomes? Research suggests that measurement-based care may improve detection of risk factors for relapse, such as craving. It may also improve a clinician's ability to identify patients who are not improving and adjust treatment protocols accordingly. Further, it may improve patient engagement and self-management, as well as patient-clinician communication and joint decision-making. Finally, tracking outcomes can be useful in communicating the value of addiction services to payers and policymakers. So this all sounds like a great idea, but does it work? I've posted some citations of the most recent literature reviews on this slide. The bottom line from the research is that it can improve outcomes, but it's not a foregone conclusion. It seems to depend on how it's implemented, and there's still more we need to learn about how to maximize its effectiveness. The second application of outcomes measurement is when a provider's patient's clinical outcomes are measured and then fed back to the provider, typically in comparison to other providers or norms or targets. Systematic reviews find that in general, provider feedback can improve outcomes. Work conducted by Wennberg in the 1960s and 70s found that clinicians will respond quickly if they see data suggesting that they're doing things that are out of the norm from their peers. You can see on the left side of the slide variation discovered by Wennberg in common medical procedures across Vermont. On the right side of the slide, you can see how the outlier procedure rates decreased rapidly once physicians were told where their procedure rate was relative to their peers. A more recent example is from CMS. Between 2013, when CMS began posting hospitals' rates of catheter-associated urinary tract infections, and 2015, the rates of those infections declined by 46%, again highlighting how powerful a tool provider feedback can be. However, measurement-based care and provider feedback are not without challenges. these including deciding what to measure, such as what domains to capture and what instruments to use to capture them. Determining how to use technology to report the measures, how to incorporate them into EHRs, how to format the data, how frequently to report it, and how to optimize its usefulness with comparisons or benchmarks. Often, moving to outcome measurement involves a significant cultural change for organizations, and that can be a challenge as well. Other challenges include determining how best to engage patients in the use of data and outcome measurement, and then finally how to measure and leverage data so that it's actually actionable by clinicians. So with that brief background, I'm very excited to introduce our first speaker, Scott Lutgenow, who will tell us a little bit about his organization, Southlight Healthcare, and how they have been successfully using outcome measurement and addressing some of these challenges.
Right, excellent. Thank you, Dr. Marks. My name is Scott Lutgenow, and I work with Southlight Healthcare in Raleigh, North Carolina, where I'm the Medication-Assisted Treatment Director. We are a nonprofit, private nonprofit offering a comprehensive array of service lines to treat the dually diagnosed. And we actually started out as a medication-assisted treatment provider in 1970. And a large majority of the clientele that we work with struggle with complex comorbidities, access to social determinants of health. And I guess it was about 2 years ago we decided to redefine the internal mission statement of our opioid treatment program. And we've changed that to wrapping medication-assisted treatment in a person and family-centered recovery culture supportive of global health and quality of life and sustained recovery. And this was really the impetus for us to start digging deeper into evaluating the work we were doing every day with the individuals we serve. We wanted to know exactly what was happening when our clinicians were meeting with our clientele. And we know the research is extensive and unassailable. Staying in recovery and avoiding a return to use for at least a year is twice as likely with medications as without them for individuals with severe opioid use disorders. But despite this, individuals seeking medication-assisted treatment still experience barriers to evidence-based treatment. They experience exclusion from mutual aid group meetings and sober living facilities, while participants in drug or recovery courts are often not given the opportunity to engage in what we know is the most successful treatment modality for severe opioid use disorders. And this was another crucial component in our quest to evaluate outcomes. How can we provide solid evidence that our programming is working to our funding sources, family and loved ones of our clientele, and the larger community that we serve? So, are you any good as a therapist? The 2012 study asked 109 different therapists to compare their psychotherapy results to those of their peers. And they found that 25% of the therapists estimated that their results were in the top 10% of all therapists, and not a single one estimated their results were below average. And simple math tells us that's impossible, or as Daniel Patrick Moynihan famously stated, you're entitled to your own opinion, but you're not entitled to your own facts. And extensive research tells us several things. Some that therapists perform exceptionally well, while others struggle. And years of experience are unlikely to matter. For example, some interns experience better results with their clients than seasoned therapists. And there's also evidence showing the specific modality of therapy used seems to contribute very little to clients' progress. And last but not least, we can directly connect the therapeutic alliance between the clinician and the client to that client's outcome and treatment. William White is quoted as saying the history of addiction treatment includes a pervasive and cautionary thread, and that's the potential to do great harm in the name of help. And there's even a technical term for such injury, iatrogenesis, or harm inflicted by a healthcare provider with the best of intentions. And we at Southlight really wanted to shift the basic relationship between our service providers and our service recipients. We wanted to create a direct window into the client experience through tracking outcomes and better discerning the end user experience. At a conference early last year, I was introduced to a senior leader at a managed care organization in the western part of our state who mentioned being impressed with an outcomes tracking system they were using called ACORN. And ACORN is an acronym for a Collaborative Outcomes Resource Network. And it was created by Dr. Jeb Brown, who has an extensive background in therapy before he went on to create outcome measurement systems for large and small-scale organizations. So the question, are you any good as a therapist, really only makes sense in the context of compared to what? So it's really benchmarking that provides therapists with a way to answer this question and to evaluate if their performance is improving over time. And that said, we wanted an outcomes tracking system that truly compared our unique data to field-specific benchmarks. Clients take a moment to populate a brief questionnaire on an inexpensive tablet that takes approximately 1 minute. And we do this at the beginning of every counseling session. Results are automatically uploaded to the cloud-based system. And what happens is it starts to paint a picture of the client's experience in treatment and their occurrence of symptoms, all while aggregating the data and comparing against field-specific benchmarks. So we review the client's answers in session and find it really facilitates the structure of the session around goal setting, treatment planning, and processing for both the client and the clinician. And so with the clinician's toolkit, this is the dashboard that appears when staff members sign in. The summary statistics tell us basic information about this clinician's caseload. And the improvement score lets us know overall how this individual's caseload is progressing. And you can see the percentage of clientele in the caseload who have significantly improved, who have somewhat improved, or who have gotten worse or stayed stagnant since starting treatment. And so now you can drill down into the individual categories on this person's caseload for each specific client, and you'll see the different metrics for each section along with a benchmark score indicating how each patient has progressed as compared to comparable patients within ACORN's database, which is made up of millions of data points. And the most important categories that we're looking for are the global distress scale, self-harm, therapeutic alliance, and clinical message. So the global distress scale is derived from the client's answers around mental illness symptomology, whether related to anxiety, depression, or mania. This really gives us a snapshot of how the client is navigating life with or without psychological flexibility. Self-harm relates to the questionnaire responses to do with suicidal ideation and self-harm, while the therapeutic alliance score relates to the client's answers around the efficacy of the relationship with the therapist. And you can click on any category for an explanation of that specific metric. For instance, clicking on the therapeutic alliance hot link, you get a link to a really good explanation of why this function is extremely useful to clinician, and it really makes it user-friendly to start with the clinician's first use. And here's an example of ACORN's explanation of the therapeutic alliance score, why it's important, and how to interpret that. And then finally, one of our favorite functions has been the clinical message feature, and it offers a high-level look at the individual status and treatment. ACORN uses a system of clinical algorithms they refer to as ROI, or Resource Optimization Intelligence. And the messages draw attention to the risk factor. They identify patients who will have the most likely to show gains with continued treatment. Also will tell us which cases are at greatest risk for premature termination with a poor outcome. So our decision to begin tracking outcomes has become an incredible supervision tool. We recently had a therapist that was on leave. One of their clients that they were working with was experiencing some suicidal ideation. Me as a clinical supervisor, I was able to go in, take a look at that, and that really sparked some interest in this specific case. We were able to get that person into our dialectical behavioral therapy program where they were resistant at the beginning, but due to continued stress of ongoing symptoms, they were much more likely to engage in DBT, and we've had a great outcome from that specific case. So it really allows us as clinical supervisors the opportunity to really gauge client progress for ourselves and the chance to identify interventions that would have otherwise been impossible to execute. And we're not currently using value-based healthcare in our area, but the conversation is becoming louder and more common. And our initial interest was to solely improve client care, staff development, and offer data to our formal and informal partners. But we're really hoping this attention to detail will prepare us for the next steps once value-based care becomes a part of our service delivery and reimbursement structure in North Carolina. And thank you for your time.
Thanks so much. We have time for a few questions. One is whether the Acorn product can be used with group therapy.
Yeah, actually it can. We're not using it for that specific function, but they are using that. There's different questionnaires available for what specific population that you're working for. You can also come up with custom questionnaires. Kind of the benefit of going with a more standard questionnaire, we use the adult recovery questionnaire. The benefit of going with that is, of course, having many other users who are using the same questionnaire and, benchmarking metrics.
Great. And we have another question from someone who says they're struggling to identify particular measures that they like for measuring substance use disorder treatment outcomes. So maybe you could reiterate again kind of what the outcomes are that you're capturing with.
Yeah, of course, absolutely. So we've got therapeutic alliance, and so a lot of the literature has shown that therapeutic alliance is really critical. So that's one of the things that we're measuring. We're also measuring substance use. Has that client been able to abstain? Are they struggling? We want to know that every time. And then we're also looking at the global distress scale, which really hits on mental illness symptomology, and that gives us the chance to create interventions very quickly for folks experiencing those symptoms. We also have a psychiatric service line, as well as DBT, intensive outpatient, and other things. So this really helps us with internal referrals and external referrals, and really making sure that we're meeting the needs of our clients, very quickly.
Great. Well, thank you so much, Scott.
Of course.
So let's now move on to our next speaker, Dr. Katie Fitzgerald, who tell us about another application of outcome measurement using a mobile phone in her clinical practice.
Hello. My name is Dr. Catherine Fitzgerald. I practice in Central Massachusetts, primarily primary care, but I also specialize in addiction medicine. So the application that we have and are developing is an application for a mobile phone, as she just said. And what we're trying to show with this application is that the more connected a patient is, especially in early recovery, the better they're going to do, the lower the dropout rates and the lower the relapse score or rate of relapse. So, oftentimes, many of you that are either therapists or doctors or any provider in this area probably have found in the past that phones have been a distraction. But nowadays everybody has one, and if anything, they're a way to connect to a patient. And we've sort of shown that with some of our research. So the app is called OARS, Opioid Addiction Recovery Support. In my office, we've actually connected it with our EMR, our electronic medical record, and it serves to do a couple of things. Of course, it connects and gathers basic information, like urine toxicology, group attendance, office attendance, those basic things. But it also synthesizes data that we normally wouldn't be able to ascertain. So things like journal entries from the patient, survey data, and with demographics that you traditionally couldn't gather so easily, such as, are you still associating with other heroin addicts? Are you still, are you still drinking excessively? Are you still smoking? Things like that? Are you looking for work? Questions that could be red flags in either direction. This data can be trended, analyzed, not just for the provider, for provider use, but also for patient use, for patient feedback. And I'll show you that in subsequent slides. We're also working on a algorithm called MATRA that helps to predict and hopefully prevent relapse, and also helps providers sort of plan their day as far as, how much time does each individual patient need, which can be helpful in office day planning. And we'll talk about that. This is a picture of what the provider portal looks like, what you'd see from the provider point of view. We do talk a lot about journaling, journaling from the stance of, classic cognitive behavioral therapy, mindfulness. This is very useful for the patient in the sense that oftentimes in addiction therapy we're talking about triggers, right? What's your trigger? And that, I think sometimes that can be sort of, sort of nuance kind of stuff. But if you can get a patient to write about this real time, like I say, everybody always has their phone on them, right? You don't always have a piece of paper to write about feelings, but you almost always have your phone. So we actually counsel patients in their appointments. You say, when you're in that moment, right, like fill in the blank. It could be a cookie. You could be creating a cookie, walking to the kitchen, and as soon as you realize, man, I'm not even hungry. This is automatic behavior. I'm just walking to the kitchen because I'm bored. But it could might as well be, I've got a craving for heroin and I'm calling my drug dealer. It's truly the same feedback mechanism, right? It's that glutamate, dopamine, that sort of automatic behavior. As soon as you realize that's what you're doing, pull out your phone and just write about how you're feeling. And if you get the patient to do it, they're writing about their trigger. And most of the time, the patients will not, if they'll do that, they won't even go on to call that dealer. They won't go on to eat that cookie, so to speak. But if they do, because they've broken that behavior pattern, but if they do actually go on to do it, when I see them in the office the next week and say, what were you thinking? They can pull out their phone and go, I was thinking this. And that's their real trigger. So we can actually trend their triggers real time, and that's been extremely useful for recovery, for figuring out what behaviors to avoid, what things are triggering them. So that's actually been a very useful application for this that we actually didn't predict. These journal entries can be transferred over directly to their electronic medical record if it's appropriate. This shows you what they can see from their phone. As you can see, they can actually make it private if they like. I can see that they journaled, and that's useful for when we're trending participation and things like that. But a lot of times they want me to see what they wrote. They want feedback from me, and that feedback's very important. Again, them feeling connected to the provider. Please read what I wrote. Please, I'm reaching out to you, and not just to the provider, but to the therapist, because the therapist can also see what they wrote. Sometimes they just want to write a smiley face or put a frowny face. It can be that simple, and that can also be trended. Okay, again, this is the MATRA. This is the algorithm that we're working on. It stands for Medication-Assisted Treatment Recovery Assessment. This is, again, our hope is that we can feed information into this algorithm to sort of predict possible relapse, and then hopefully the hope is to prevent it. And we're always tweaking this. This is something that we use the real-time data like the urine toxicologies and group participation, et cetera, but we also are using the surveys to feed this. So surveys are given when they initially come into treatment. They're given monthly, and then they're also given after they have a quote-unquote, dirty urine. That's not appropriate, but to tweak it. Like, were we accurate? Did we see this coming? Do we need to tweak it in any way? Like, were we surprised by this? So we're always kind of changing this algorithm up. And again, on a less important note, we also want to use it to change up our office schedule. So if someone is less acute, maybe they only need 5 minutes for the office visit. This can be very quick appointments. If somebody is in more crisis, can we predict that and give them 20, 30 minutes? Do they need more? Do they need to see me and see the therapist at the same office visit? That kind of a thing. So it's used for office management as well. This is kind of what the surveys look like there. Pretty basic. The patients can see their own urine results oftentimes before they even see me because they come back pretty quickly. And you can see on the right here, they're pretty detailed if they want to see that. They can also choose to see sort of a dumbed-down version, which is little smiley faces and that kind of thing. Like yellow just may be positive for marijuana or some alcohol. Not necessarily preferred, but may not be a deal breaker. It's not red like heroin or red like cocaine. And green is perfect, but they can also trend their buprenorphine levels, norbuprenorphine levels. And that's handy for people who are weaning, because I do have a weaning program. So sometimes when they're weaning, they actually want to see those levels trend down over time. They have certain goals they're looking for, so it's useful for them. We do have a education library with a whole group area where people go and they'll post their own videos for education purposes. They'll post, or maybe they'll want to see what happened in group that they missed the week before. They have sort of a virtual sponsor kind of a thing. So I just wanted to show you that part. And this is also where you can trend. Patients do sometimes like to see this to sort of analyze the results over time. Again, when they're weaning, they'll like to see, they can kind of extrapolate, if I continue at this rate, then of this rate of weaning, then I'll be off of Suboxone by this date, So they like to set little goals, and you can tweak it at the bottom here. You can tweak hide participation or hide, these different kind of on that x-axis. So it can be useful for them to kind of play with those numbers and set their own goals. So what I hope to show with this actually is just that the more connected the patient is, not just with me, and even with the nursing staff, but also with the therapist, the better they'll do, and the lower their dropout rates, and in general, lower the relapse rates. So, any questions?
Thank you so much, Dr. Fitzgerald. We had one question about the extent to which patients actually have mobile phones. You mentioned that most patients have them. Is that your experience? And then I guess what happens if they don't?
Yeah, actually, it's funny. I probably have probably right now out of office panel, I have probably about 150 active Suboxone patients right now, and there's probably about 5 of those that refuse to use a mobile phone. And so that's okay. I mean, they just don't want to, and that's fine. So they don't have to use it. I mean, that's okay. It's just an option. So whatever. I mean, teach his own. I mean, we still see them, and they still come to group, and they're still part of the program. But I mean, so it is what it is. But I feel like for the most part, almost everybody, at least in our area, has some form of a smartphone. This may not be politically correct, but they call them Obama phones. Like everybody has one. It seems like. So it wasn't very difficult to get everybody on them, and money didn't seem to be an issue. Mm-hmm. So you know what I mean? I mean, everybody seemed to have some. Minutes might be an issue towards the end of the month, but everybody seemed to have one.
Mm-hmm. And we had another question about whether patients would feel resistant or try to report more positive findings if they know that the information is being shared with their provider, or if they feel like people are encouraged to be honest.
I haven't really. I haven't really found that. If anything, they don't say anything at all. The ones that do actually journal tend to only journal more negative findings. It's kind of odd, like you would think maybe they would just be all roses, but when they actually do journal, it's when they're feeling down. So when the people do journal positive information, it's mainly smiley faces. I don't, just a little smiley face. I don't get a lot of written positivity. I get mainly when they do journal, it's because they want to reach out. So that's interesting. But yeah, I don't get just a lot of positivity for no reason.
We have a whole bunch of questions, some of which we may be able to come back to at the end. Really interesting, great questions. So any concerns about HIPAA?
Oh, it is HIPAA compliant. We went through a lot of vetting with our IT department. Obviously, we had to do that. And every patient has signed. We're working with our local universities, with Tufts and UMass as well. We have several PhD students that we're working with this algorithm. So we have graduate students working with us as well. I'm a professor at University of Massachusetts as well. So we had to go through IRB and all of that. So all of the patients are aware that some of this data is being used for research and things like that. So they've signed releases and they understand all of that. So we're using the information in a very vague way, of course, and and just to be clear, on the app itself, patients do not. This information is I can see it, and the other providers can see it, but patients can't see other patients' data, right? So I'm going to be very clear about that. There's a group room where patients can see other patients commenting, almost like Facebook, but other patients can't see other patients' journal entries or anything like that. So that's you know what I mean. So that's there's a privacy area there where that's safe, so to speak. There's a safe that's blocked off, and their names are private. So in a way, that virtual sponsorship is very safe too, in the sense that we wanted to find a way where patients could reach out to each other outside of a group without having to give their phone numbers or give personal information, because that can get very awkward as well in a recovery setting. So this is sort of a safe way of doing that. But yes, it is HIPAA compliant. There's not it had to be able to cross over to our EMR.
Mm-hmm. Can you say a little more about how it encourages engagement?
Well, a lot of people, especially like I said in early recovery, are afraid to kind of leave sort of the safety and privacy of what they know, especially their own home. There's a lot of stigma with addiction and early recovery, and I found that's one reason why I think going for recovery treatment with your primary care doctor is a little bit easier than going to, say, a standalone addiction center, because people just think you're going to your doctor, right? So that's a little easier, but it's hard to go to a group for the first time if you've never been to a group. It's hard to go to, to get treatment, ask for help. But it's a little bit easier if you can reach out through an app, right? It's a little bit easier if you can reach out for help through something. That's why I think Facebook and other kind of apps are easier for people, especially of this younger generation, that they're used to doing that. So if you can get them to reach out to an app, and they're more willing to do that. Now, I require they do both. Obviously, they have to come to groups, they have to come see me, but this is an added avenue. It's an added avenue of, please reach out and talk to me. Please reach out and talk to the nurse. Please reach out to your peers if you need something. Here's another way to do it. And so they don't isolate. They don't cocoon. And that's so important. And usually they'll warm up and they'll kind of, okay, this is a safe place. I do trust everybody. But I just think it's just another tool in the tool belt, to make them feel they're part of a community, a recovery community, which is so crucial.
Mm-hmm. Yeah, it's fascinating. It's really, really fascinating. We have a lot more questions, but we're going to keep going to the next presenter, and then we'll come back and have more time to answer questions at the end.
Okay, great.
So thank you so much.
Of course.
So happy to introduce our fourth speaker, Karen Haberlin, who will tell us about how the state of Connecticut, the Department of Mental Health and Addiction Services, is using provider feedback as a quality improvement tool. Karen, you're up.
I apologize. I had myself on mute. Hi, everyone. I'm here from the Connecticut Department of Mental Health and Addiction Services, called DMHAS for short. We're the lead agency for addiction treatment in the state. We fund over 300 programs and over 50 private nonprofit providers. We also have some medically managed detox and intensive residential services in state facilities. We provide a wide array of services ranging from detox and rehab down to outpatient, case management, and recovery supports. DMHAS started tracking outcome measures about 10 years ago in 2009. Our state legislature had a results-based accountability initiative that required us to identify and follow cross-cutting outcome measures at our agency. And in addition to the RBA work, we developed provider-level, what we called report cards. They were very dense. They had a lot of numbers and red text indicating where organizations were deficient. And we received feedback from our community that this manner of communicating the data was not the most user-friendly. So consequently, over the next couple of years, we started refining our product as well as our process. So we launched a redesigned quality report in 2013. We try not to call them report cards anymore. Did I skip over this? Okay. They're a more visual format, as you can see. This is a sample from a methadone maintenance program. There was a collaborative effort between my division, the quality division, IT, and the community services divisions. We developed them in-house. We issue these reports quarterly, and they're published on the web. I think I am missing a slide. I apologize for a second. We can get that URL out for you, but we publish them online on our website. Outcome measures and goals vary by level of care or treatment modality. For example, we're measuring different outcomes for detox and outpatient. The reports contain data that we collect in compliance with federal block grant requirements, such as the national outcome measures and the treatment episode data set, the NOMs and the TEDs, as well as additional data elements. So before we go into more detail, I wanted to show you an example of how an outcome has improved over time for several different treatment modalities. This line graph shows treatment completion rates for outpatient, intensive outpatient, high-intensity residential, and transitional halfway house levels of care. And as you can see, in each case, treatment completion rates have increased over the past 5 years, and we believe that there's two main reasons for this. First, it may be the result of better quality data. When providers know that their results will be public, they make sure that things are coded correctly. And secondly, we believe that providers are working to meet and exceed the target rates that we set, and they set their own goals as well. So let's go back to that sample report. This is an actual report. I've redacted it. It is for a methadone maintenance program, and this slide shows how the report looks in its entirety. Each what we call program has one page, and some providers have many pages in their PDF. So let me just go to the key. The gold bars represent the actual reported values. We have vertical black lines that indicate the goal. Green check marks denote that a goal was met. A red dot indicates that a goal was not met. We have arrows denoting variances of 10% or more. So let's go to the first section of this. We can see that it just lists some really basic, not demographics, but frequencies, such as the number of unique clients, admissions, discharges, and counts for service hours. I'm using an end-of-the-year report here, so we can actually compare the counts from the year assessed against the previous year for this program, and take a look at it. Note while the number of admissions and discharges has decreased somewhat, the actual number of service hours has increased from the previous year. This suggests stability, that people are staying in the program, they're not leaving, and they're receiving more services. We have a recovery section of outcome measures, and these use the national outcome measures, national recovery measures. So we're looking at arrests, abstinence or reduction in drug use, improved or maintained GAF score, living situation, usage of self-help programs, and employment status. So we set goals for each of these outcome measures by each level of care and reassess them periodically. And as you can see in the fourth column of numbers, we provide the state average. So the state average can help us see if a goal needs adjustment in later reporting periods. So looking at this particular program, it's meeting or exceeding each goal, and the green up arrows show that the goals where it's doing really well. Not all levels of care within the DMHAS treatment system require service reporting, but in this case, methadone maintenance does. We take a look at the number of clients receiving at least one service during the reporting period, and we calculate a percentage of how many have received at least one service over the last year in this case. And once again, this program has met its goal. We have a discharge outcomes section. We look at the rate of successful treatment completions, and in this case, this program is a little shy of the goal of 50%, but looking at the state average, you see that the state average itself is lower than the goal. It's 48%, and this program is 47%. For medication-assisted treatment, we have a service engagement measure. We look at the number and percentage of people who stay active in the MAT treatment program for over 1 year because it's a long-term treatment and we want people to stay in. So in this case, it looks like there are a large number of people who are staying in for longer than 1 year. We are currently testing a new measure that would complement this one. It counts the number of people who've dropped out of treatment, that is, they've been discharged without successful treatment completion in fewer than 30 days, and we're working on including that in our subsequent outcome reports. So finally, just a few tips for implementing your own dashboard. I can't emphasize enough that it's important to make the process non-threatening. A lot of our providers in our community, because we do contracts for service, we're very intimidated by the idea of outcome reports published in a public website because they felt that this would lead to being defunded. And we had to really reassure folks that this would not be the case, especially while we were developing these reports, because we knew that this was going to take a lot of work and a lot of finessing in order to get things to work properly. We often have data issues where maybe through various technological problems, data may not have gotten in, or perhaps the actual outcome report isn't calculating correctly. So we basically had to just be very open and honest about our process. Involve as many stakeholders as possible, particularly staff from the programs you plan to assess, and include a range of staff, direct line staff, managers, quality people. You want as much feedback as possible. We build in a draft review period to obtain feedback on the quality reports within each reporting cycle. So as I said before, we do this quarterly. So what we do is we issue draft quality reports to key contacts at each provider agency and give them a timeline for giving us feedback. And then once we meet the deadline and we don't have any comments or we resolve issues, we do what we call the production reports, and those are then uploaded to our website. Visual elements such as color and layout are important. I mentioned the somewhat stressful impact of red text early in our quality reporting career, and it really does connote a lot of anxiety and problems, and if we can just make something a little easier for everyone to work with, that works well. And finally, as I mentioned before, we want to adjust goals as necessary. You saw in one of the outcomes that we weren't even meeting our own goal statewide, so perhaps that's something that we leave as is, or perhaps we want to modify that somewhat. Or sometimes we set goals too conservatively and everyone is acing them. Well, obviously we can find a way to do better, and perhaps we want to raise the goal percentage. So that's all I have. Thank you very much.
Thank you so much, Karen. We have a few questions. One question is about the frequency of the data collection. Is the data on the outcome measures just collected at admission and discharge, or is it collected more frequently?
So we collect data at admission, periodic assessment, and discharge. Periodic assessment would be every 30 days or so. We require that providers either enter their data for the last month by the 15th of the following month. So for example, January data is due on February 15th. Either enter it into our online system or upload it through Extract.
Great. Another question was about moving across levels of care. Can you talk a little bit about how that is captured?
Yes, that's actually kind of complicated, and we have some documentation on our website about that. We do look at continuity of care, particularly in the outpatient programs. We want to see people staying within programs. So if someone has been discharged from a high level of care like residential and is stepping down, that's not really considered a discharge in our parlance. It really depends on what's going on, and there's documentation on our site that I'd be happy to provide, but we do account for what we call transfers and true discharges.
Can you talk a little bit about the feedback that you've received from providers on the reports, and if it resonates with them, and if it feels like it's accurate to them, useful to them?
Yeah, we've gotten a lot of positive feedback, but it took a number of years. I mean, it's 2019 now. We started back in 2013, 2014. We have done a lot of education around these provider quality reports. We have bi-monthly provider quality conference calls where everyone calls in to a conference line and we talk about data quality issues and share news, talk about the development of the report cards, things like that. We also have forums a couple times a year. We have a large state hospital with an auditorium, so we have people come. It's a central location in Connecticut, and Connecticut being small, it's really easy for people to get to. So those are opportunities for us to talk about issues and hash out any problems that people have, any questions. We've also just encouraged people to email or call us with questions. So early on in the process, we definitely got a lot of feedback about, I'm not sure if this is capturing our results accurately, and sometimes we would find that maybe in one case it was that the provider was using a discharge reason that wasn't accurate, and maybe in another case we had a calculation problem. We had a log for the first couple of years of all the questions and comments that people made, and we would go through this log religiously on a weekly basis. Nowadays, we don't really get that much feedback anymore. People just, they review their provider quality reports and they're good to go. And if for some reason we're running late, they want to know where they are. They really want to get them.
Great. Thank you so much. We have 10 minutes left, so I'm going to open up for questions for any of the presenters. I noticed that we got one question that would be open for any of our presenters, which is to talk a little bit about how other staff might be used to help in the data collection, other non-clinical staff. So it's essentially a question about how do you create an infrastructure to make sure that you're collecting the data as part of your workflow. So I'll open that up to any of the three of you to jump in and respond to.
So our clinicians are actually solely responsible for collecting the survey data, and we feel like that works really well. We are tuned into what our clients' experience is of administrative staff, such as front desk staff. So we go through quarterly and do surveys around our client experience in that regard, but that's all we're doing.
Great. And maybe, Dr. Fitzgerald, you could talk a little bit more about how the data flows into your EHR, because that seems like a workflow strength.
Yeah, well, there's actually a button, there's a little tab in the OARS app that from the provider dashboard where you can choose, to send this over as a PDF into the EHR. So, because not everything is appropriate to be sent over to the EHR. Sometimes sometimes the messages are sort of mundane, like, hey, when was my appointment time? That doesn't need to go over, or things like that. But if it's a particularly important journal entry, or maybe somebody was saying something like, I'm feeling suicidal, or something like that, or something very important about their mood or whatever, and I want that as part of their medical record, you just hit a button and it says, we'll change to PDF and transfer to the medical record. So it's actually really user-friendly. Like an entire exchange can be copied back and forth over, so not just what I wrote, but what they wrote back and forth. So it's just a button. It's easy. But yeah, we do surveys. The graduate students when they come in, they do surveys. I administer surveys. The surveys pop up in their phones. So the patients have self-administered surveys. It seems a little mundane, but they're short. We don't want people to get burnout either. They're 5-6 questions, and they're pretty quick. So they're pointed, and they're tailored to the patient and kind of what they're based on their MATRA score. So if they're not doing very well, they're sort of pointed towards that, So it's I wish I had some examples loaded to show you, but we really do want to avoid sort of burning people out. So 30 question surveys are not the way to go. They won't get done.
Yeah, it's fascinating that you're using just smiley faces as an outcome measure.
Yeah, well, because it's funny because it'll sort of, even that can be, trended.
We have a question for any of the presenters. What's the biggest challenge you face to optimize your outcome measurement system? The challenge that you faced and that you overcome. Let's put it that way. So maybe we can just start with you, Dr. Fitzgerald, and go around.
Something that I've faced and I've already overcome, or that I'm trying to overcome?
Well, either one.
Wow, that's hard. There's so many challenges. All right. Well, I guess the biggest challenge would be access to therapy for all of my patients. But gathering data. Okay. Well, participation is a big one. A big one because not everybody utilizes the app like I want them to. I have about 50% of them that do it regularly and are very good about it, and I have the other 50% only use it when they're in crisis. So that obviously skews data. So I can assume that the other 50% of the time things are rosy, but so we're trying to work with patients to be a little bit more consistent, and to participate more with a group aspect. But at the end of the day, if the end goal is that they're just doing better in the recovery, then that's great. But as far as research, it does skew my data a little bit. But I guess that's all right if they're doing better in recovery. But as far as data is concerned, it does skew some of those outcome measures a little bit.
How about Scott? Any challenges you want to talk about?
Yeah, I think another audience member had asked about this. I think our biggest challenge was getting the buy-in of the clinicians to kind of open the curtain and see what's going on in those sessions and what's the value. How are we going to use the information? Was this going to be a part of, for instance, their evaluation process? And clearly that wasn't going to be the case. And we had the founders of the organization of ACORN do an informational webinar with our staff, and so that helped out a lot to get the buy-in there. And just making this a part of the experience for our clients, so they know that they're going to fill out this questionnaire when they come in. Again, it only takes about a minute. It's very, very quick. Now, a lot of our clients look forward to filling that out. They think about how they might answer those questions in between sessions. So I think that the proof is in the pudding, and our clinicians have really started to see the value there. And, sometimes folks will disclose things in their survey that they know they're about to hand over to their clinicians that they might not verbally express to them in that session. And so we've seen a lot of kind of remarkable strides made with the Therapeutic Alliance, with our clientele, and then also, of course, with the clinicians buy-in. And so once they were on board, we felt really good about the data and the way that it was being handled. And so that was our biggest challenge.
Thanks. Karen, do you want to take that one as well?
Yes, I think one of our biggest challenges was that we used a consultant to develop the provider quality reports, and with budget problems a couple of years ago, as well as his desire to work in the New York City area, he left, and we had a few months of scrambling to try and figure out how were we going to maintain these, but we do have some staff who have learned how to do the various processes that are behind producing them, but that was very frightening for us for a while because it was really just one person doing a lot of the work. So don't do that.
Okay. Duly noted. Are you, I don't think Connecticut is doing this, but are you tying any of the outcomes to any financial incentives?
We do not do incentives at this time. We do, someone had asked a question about outcome measures, I think. We do have these measures in our contracts. So generally speaking, they are tied to contracts, but we made sure to be clear that that the assessment of how well a provider or program is doing is not just dependent on what is produced in the provider quality report. Other information goes into that as well.
Terrific. So we're heading into our last couple minutes here. I want folks to know that NADAC credit is available. You just need to stay on the platform. Thank you all for participating. The slides will be available in a PDF form, and feel free to follow up with any of the presenters or myself if you have additional questions. This is a complex topic. There's a lot to talk about, and we really appreciate your interest. And with that, we'll conclude. Thank you all.